right, good morning once again. And in case you are just joining us, karibu sana. We are now shifting gears to talk about Matters Health, being Wednesday. On the health segment this morning, we want to talk about maternal health and looking at the progress we have made in the country, some of the initiatives that have been put in place and how partners are collaborating to be able to address this crisis in the country. In studio this morning, I'm hosting Dr. Helen Kiarie. She's the head of Monitoring and Evaluation Division at the Ministry of Health. Thank you so much for creating time. We also have with us Caroline Wainaina. She's a research officer and a project manager at the African Population and Health Research Center. Karibu sana. All right. It's usually nice to begin by looking at the depth of the crisis and how the numbers look like. And let me begin with you, Daktari. Just if you look at the mortality trend in the country, in Kenya, what would you say, where are we at compared to even the neighboring countries?
Okay, so thank you very much, Safin, for inviting us to speak about this important issue on maternal health and issues relating to that. So in terms of maternal health, maternal mortality is a very unfortunate occurrence that is taken very seriously within the facility where it occurs and also within the health system as a whole, because if a mother dies when they are giving care, then I mean it's really one of the issues that we don't want to happen, and we try to arrest as much as possible. And this particular indicator is one of the most critical indicators that is tracked by a health system. So in Kenya right now, the current estimate on maternal mortality, and this is the number of mothers that die within a period out of every 100,000 deliveries, that is how it is defined, is currently estimated at 355, and this is as per the latest data. This is the Kenya household population census that was done in 2019. So these kind of surveys are the ones that give us estimates like this. So 355 was a drop of about 7 points from 2014 when it was estimated at 362. And this, as you can see, the decline has been extremely slow or very small. So we feel like we are not doing very well. The neighboring countries, Uganda is estimated at about 284 and Tanzania 238. We have a bit of queries on the data. Usually when the source is the population census, the estimate is usually higher than if the source is what is called the demographic health survey, which is the KDHS, which is what would give Tanzania and Uganda the estimates that they have. So currently we are sort of trying to see how we can best get a more accurate estimate, because we think as much as it is still not it is still at that 355. We need to establish the actual estimate, and those mechanisms are already in place. Right. So this is where we are at. Whichever we look at it, it is still higher than what we would want to see.
In fact, it should be 0 if you ask me. Yeah?
Yeah.
Even 1 is not a good number.
Yeah,
no mother deserves to die while bringing forth life or taking care of a young baby. You know, it should be 0 if you ask me. If we can achieve that, the better. But Caroline, what do you think are some of the factors that are contributing to this persistently high rates of mortality in our country, and even that sluggish drop from 2016 to 2019, just a drop of 4 is not something to write home about.
Very true. And I agree with both of you in terms of no woman should die giving birth. It's quite an unfortunate event. And I'm a mother myself, and so I feel when I hear another mother has died, because a mother, the health of a mother affects the health of a population. You take care of a mother, you've taken care of a generation. And so a mother dying really impacts the population as a whole. And one of the reasons that this is persistent is the health system aspect, where, I mean, women come into a health facility, but the health facility on its own does not have the capacity to handle, for example, complications that may come as a result of the pregnancy or as a result of the childbirth. And in that case, you find then a woman is vulnerable to the risk of dying. Another would be socioeconomic issues that the woman herself goes through. Because you find there are women who, for example, in the remote areas, in the rural areas, access to a health facility is not as easy as it is in an urban area. You find women really struggle in terms of distance to the health facilities, in terms of even financial access. Because you find, one, you either need money to access the facility or you need money to access the services. So you find then that also delays women getting to healthcare, women getting the access to the services, which again can complicate whatever issue they might have, leading to delayed response by the healthcare staff. And I mean, if we look at COVID-19, it affected everyone, but largely it affected women, because you find resources had to be redistributed. And therefore you find, for example, staff who are supposed to be on standby were now had their hands full with other things. So you find, again, that also increased the risk of women being, complications being picked up early. So some of those factors are persistent. We are working towards, for example, like health information for women, improving access to health facilities in terms of financial, like health insurance, in terms of building facilities close to communities, so that then we are sort of merging that gap. But there's still a challenge. A challenge
that is there.
Yeah.
Dr. As you add on what she has mentioned in terms of the drivers of these high mortality rates in our country, also tell us how the interventions that we currently have in our country are sensitive to some of these challenges. Are we thinking of coming up with solutions that are actually looking into the kind of complexities women are dealing with in Kenya?
Okay, yes, the government, and this is national and county government, has been dealing with this challenge for some time. In as much as we are still having high mortality, I think a lot of progress has been made. And just to speak to the issues that Caroline has raised, the issue of financial access is a major barrier. So because if a woman does not have financial resources to afford to go to a health facility, then they will not go. They will probably decide to give birth at home. So issues, and even just going to the facility before she gets she delivers, and immediately after delivery. So the government put in place a mechanism to finance to support mothers in this aspect, and this is the free maternity service, which was also called Leader Mama, and I think a huge number of women have been able to access free maternity services in facilities using the Leader Mama service, and this is one of the ways that this has been dealt with. There's the issue that also Carol has raised in terms of the readiness of the facility to respond to the mother's need, especially during delivery and even before, when seeking antenatal care and after delivery. And this, so in the last, especially in the last decade since devolution, a lot of investments have been made, and even especially by counties, to ensure that, number one, we have enough facilities available so that we reduce the barrier of distance. So we have had quite a significant increase in the number of facilities that are available, that have been put up, and this helps mothers access these facilities. The other aspect that is extremely important is making sure that these facilities have the staff, have the infrastructure, and this is the rooms, the building, a room, a delivery room that has running water, that has a washroom that the mother can access even at night, a warm shower. So these are some of the issues that we have really been pushing to have facilities. As much as they are there, they need to have this kind of infrastructure, equipment. This is delivery beds, having oxygen ready, even having enough number of facilities.
But are we there yet, Daktari?
Not yet. So I'm just reporting on the progressively what has been done. So investments have been done towards these areas. We did an assessment last year, the facility census of all facilities in Kenya, to assess some of these issues, and we are not there yet. We found that about 40% of all our facilities, about 14,000 facilities, both private, public, and those owned by faith-based organizations. Out of these 14,000, only about 40% are able to provide basic maternity services. And out of these, for example, only 27% actually have what it takes to provide this care. So this means that a facility could be offering maternity services, but when you go there, you find that they don't actually have, say, a qualified maybe staff, although this is rare. But even when the staff is there, they are not there in adequate numbers.
All right.
So, for example, enough number of nurses. So we are not there yet. So other issues that affect health-seeking behavior is experience with care. So one of the issues that mothers shy away from is facilities that when they have experience that is not respectful, that is not responsive to her needs, that is not involving her in decision making. So there's a lot of policy shift both globally and within the health sector towards person-centered, what we call person-centered care, so that the person is at the center of the decisions being made around her treatment. So this is progressively catching up. So we are not there, but I believe we are heading there.
All right.
The mechanisms are there.
All right, I like the optimism though. But despite the financial aspect of what we've talked about, Caroline, probably looking at even other aspects like cultural beliefs and the lack of empowerment of women, how these intersect with the challenges that we're describing about. Also talk to us about those two aspects of it. There's culture also.
Oh yes, oh yes, there is, and I mean, we are a patriarchal society, unfortunately. And so a lot of decision making done in the household is done by the men. And you find, for example, if it's health insurance, it's the man who is the primary person. And so the women are dependents. And so even in seeking healthcare, they actually need permission from the husbands. And this happens a lot in the rural areas, where you find women will have to first inquire, ask, or even have the presence of the husband before they're actually able to access healthcare. There's also the issue of the staff that are working on them. For example, when you look at the Somali communities, you find women, or I may say Muslim communities, you find like women don't want to be handled by men, because, I mean, it's not culturally acceptable. So you find most of them will also have a challenge going to health facilities where they can't find female professionals. And then we already have, the belief of whatever I'm going through is not healthcare associated. It's something that I can just go, to a religious person to help me with it, or I can go to a traditional healer to access what I need. So there are those ones that, of course, hinder access. In terms of empowerment, one thing that we have been doing is, trying to engage women to ensure that they understand that they have a right to healthcare. And that is, through health, health information, empowering them with information, empowering community health volunteers or community health promoters who work with these communities so that they are able to speak to them about the importance of going to health cares, the importance of attending ANCs. We had a project in Kakamega, and one of the things the women were talking about that caused them not to go for ANC first initiation, it was because I don't want to speak about my pregnancy until I'm in the second trimester.
Trimester, yeah.
And this was because, if I say, then I'll lose the baby.
Superstitious belief.
Yes, yes. So you find they don't start ANC immediately. They will start at second or third trimester. And by then, if there was anything that should have been captured, would not have been captured. So some of those things really hinder access and use of healthcare. And those are some of the things that, going forward, we need to look at beyond just the system. We also need to look at what is it that we need to change or improve at the community level.
What do they know? How do they understand maternal health?
Yes.
Work with that knowledge.
Yes.
To give them probably what right information they need to have, or even change the wrong information that they could be having about maternal health.
Yes.
Before we even talk about budgets and policies and what needs to be done, what do the communities understand about the state of maternal health care at that level? That's a good point.
Yeah.
I also want to look at the uptake, probably based on the interventions that have been put in place. Daktari, what's the current uptake of probably the ANC, going to the hospital, seeking the skilled healthcare for mothers? How are we looking like in that front? Yeah.
So I think in terms of uptake of services, we are talking about the first contact, as Caroline has indicated. That is the first ANC. This is attending antenatal care clinics is very important, because if there are issues with the pregnancy, they can be picked up early. Again, the mother is able to be advised on what she needs to do, what supplements she need to, what she needs to take. If she needs to, for example, take some supplements, for example, that are given during pregnancy. So we usually track 4 antenatal care visits, and the first one should happen within the first 3 months of the pregnancy. This is the first trimester. So currently we have almost all mothers seeking first antenatal care. That is 98% of all mothers seeking antenatal care. However, we have only 30% of these happening within the first trimester. The current data indicates that most women go for their first antenatal care between 4th and 6th month. So this is both sort of a good indication, but also there's work to be done to make sure that these mothers come early, because again,
other than the superstitious beliefs, have you identified any other reason that could be making women come late for ANC?
I think there are some factors that are associated with seeking ANC behavior. For example, mothers' education, mothers with the lower level education, those who have not gone to school, those who maybe who have only primary school education, tend to come to the clinic much later. Again, mothers from maybe some geographical regions, for example, the arid and semi-arid areas, which also happen to to also have other indicators also trailing behind. So these kind of things affect seeking of an antenatal care. So just mothers' education is extremely important. Educating mothers so that they are knowledgeable on seeking care and why it's important. So again, even finance access, how much resources someone has access to affects this, because if someone is going for casual work every day, then when they go to the clinic for an antenatal care, then there's lost income in that aspect. So you find that, again, mothers from higher wealth quintile, what we call higher wealth quintile, or mothers who have access to higher income tend to have a higher number of visits, or they're able to come to the facility much earlier and much more. Yeah. So again, the fourth visit, the fourth ANC, this we are currently at about 66%. So this is another indicator that we need to work on, but we have improved because I think 2014 were around 57 or or thereabouts. In terms of deliveries, because this is really the most important, because we want all mothers to deliver in health institutions where there is a skilled person, either a midwife, a nurse, a doctor, to help the mother deliver and deal with any complication if it happens. So out of all the mothers who deliver in Kenya, about 9 of every 10 deliver in health facilities. So this is about 89%. So this is a very good indication, and this has increased from about 65% about 10 years ago. So we are headed in the right direction, because when mothers come to deliver in health facilities, then it is possible, for example, if there is a complication, that the health worker will be able to address that. If she needs maybe referral, if she's in a health center, she needs to be referred quickly to a hospital where she needs to do a cesarean section or something of the sort, then there's an ambulance and she can be able to be transferred. So these interventions are possible in a health facility.
All right. Something also just out of curiosity, Carol, does mental health have a nexus with maternal health? Are they related in any way? And should we begin to think about how then we infuse mental health into maternal health care?
Thank you. That's a very important question you've asked. And she mentioned something about respect for maternity care. And most of the times you find for a woman to experience a mental disorder, it's because of a previous experience. And this could be related to her maternal health care experience, or it could be, for example, something that she encountered at home that could still hinder her from accessing healthcare. Because if you have a bad experience in the hospital, you will definitely not go back either to that facility or to a facility. And that impacts on your mental health. Because remember, it's all about how you respond and cope to normal stresses of life. And therefore, if in that case, this is such a stressful trigger, it will hinder you from accessing that particular service. At home, domestic violence, for example, is one risk factor that actually leads to women getting a lot of stress. Women tend to isolate themselves, low self-esteem, low confidence, decision-making power, and all those things are needed for women to actually take up agency and utilize healthcare. So maternal mental health is very important and a critical component to the healthcare of women. And it needs to be actually taken up. And unfortunately, we don't really see it even at the health facility in terms of the support for the women. Because, we have the continuum of care where we talk about looking at women, caring for women from when they're pregnant all the way to when the child is 1 year old. And you find that after the child is born, women are rarely monitored to find out how are you doing. It's always about how is the child doing. And so you find after, for example, Linda Mama goes up to 3 months. After 3 months, then what happens?
And there's postpartum depression.
Thank you.
All those manner of things.
Yes. Yeah? So you find the woman sort of dissociates herself because of all these other factors that are risk factors keeping her away from essential care.
Yeah.
Yeah.
I know you could be having something to add on to that, because we never really think about how mental health is correlated with maternal health as well. Yeah. Even the self-esteem issues that women go through, their bodies change after giving birth. There's a lot that they are going through, going back to work. Just dealing with the work environment and all that. Do we really think about interventions that infuse both mental and the other aspects of maternal health care, Daktari?
Yeah, I think this is an important issue that
or it's a new dimension.
It's a new dimension
that we should be going into.
Certainly, they are currently, maybe if there are strategies that are there, they are maybe still at really not very fully implemented. But I think this is a really important issue to really prioritize and maybe just come up with some interventions around it to make sure that mothers get the support they need. Unfortunately, mental health services as a whole is one of the areas that that is not has not been prioritized quite a bit in the recent past. But in the recent year, this discussion is picking up, and I expect that it will carry maternal mental health along with it. So,
all right.
Yeah. So
all right. Unfortunately, I've run out of time for this conversation, but as we wind up as part of your parting shot, I'd just like us to look at what then do we do? What sort of technological innovations do we need? Community-based interventions, you name it. What is it that we need to do going forward, and who needs to do what in terms of partnerships? You could even cite what you have done in terms of collaborations, the government, the non-government organizations. What is it that we need, or what has worked that we should sustain as we wind up? Let me begin with you, Carol.
All right, thank you. I think Helen said something that was very key, putting the woman at the center of the conversation, meaning that whatever interventions we carry out need to look at the woman as the beneficiary, not in terms of what do we need to do, but what does she want to make her life better, successful, and her to thrive in the world. And some of the key interventions that have been carried out and tried out are mobile-based interventions. Because as we say, the remote areas, a lot of women don't have immediate access to health facilities, but they do have access to community health volunteers, the community health promoters. And so through mobile applications, we've been able to strengthen, capacity build health promoters so they're able to now pass health information to the women. We've been able also to work with the Ministry of Health to strengthen the capacity for the health information system process, and also in terms of, for example, like emergency referrals, because that's another thing that really lacks. You find that, yes, we have everything within the normal conditions, but what about in terms of emergencies? So we've been working with MOH to just try and see, through evidence generation, how can we provide information that they can use to implement programs that are efficient and targeted to the population in need.
Daktari?
Okay, so just picking up on where she has left. So we have been working closely with the APHRC and a project called the Countdown to 2030 project. And one of the areas, for example, we studied a while ago is some of the mothers that are left behind, mothers and children that are left behind. And this is the urban poor. And we had a project where in many countries in Africa, we are looking at what is a health profile, what is a maternal health and child health like among the urban poor, and that would be maybe people who are living in the slums. And we found that there's a huge difference, and even some of the analysis we've done, we've seen that even maternal health adverse outcomes are higher among the urban poor, and this is because they're not able to access good quality facilities. So in some cases, you find a lot of small private facilities where they have to pay, but the care is not very good. I think in terms of going forward, there are projects that are really addressing some of the issues. There's a project that, for example, is already coming up to address the issue of referrals, so that mothers, so that within the community, drivers are identified who can drive mothers to hospital when they need to. And this project is called M-Mama. There's also a lot of focus on primary health care that prioritizes care at the lowest level. And of course, this starts with the taking advantage of the community health promoters to make sure that they are providing the services and educating the mothers even within community groups so that mothers have the right education that they need and they're able to also access funds within their community units in terms of seeking care.
Thank you so much. I believe if we had more time, we could continue talking about this. It's a very passionate discussion, especially considering the fact that we all agree that no mother, no woman needs to die while bringing a child into this world. That's the most unfair punishment, if you ask me, that a woman can get. So all needs to be done to ensure that, our mothers don't lose their lives because they've taken that decision to bring a life into this world. I was hosting this morning Dr. Helen Kiarie. She's the head of Monitoring and Evaluation Division at the Ministry of Health, and Caroline Wainaina, a research officer and project manager at the African Population and Health Research Center. Thank you, ladies, for creating time, and thank you for watching as well and for interacting with us on Daybreak this morning. Have a lovely day ahead and keep watching Citizen Television. We still have more that we have lined up for you. My name is Safina Chiengoma. Have a lovely day ahead.